A very young female in her 50s presented with a 2.8 centimeter cyst in the body of the pancreas. She had a eus-fna performed. The CEA was low, the amylase was high, and the cytology was inconclusive. So she was told that she likely had a pancreatic pseudocyst. 2 years later, she had a repeat CT scan, which showed that the cyst had grown slightly to about 3 centimeters. Again, eus-fna was repeated with basically the same results. Then 3 years later, she had a CT scan which showed that the cyst had increased to 3.4 centimeters. So she was sent to our institution for a repeat eus-fna. So we also performed needle-based CLE, and we found the epithelial structures that have been validated in the INSPECT study, specifically the finger-like projections, the dark ring with the white core. And interestingly, her fluid analysis, again, her CEA was very low, around 30. The cytology was inconclusive. But in addition, we sent a molecular analysis for DNA, and the report was that it was non-mucinous. There was no positive KRAS, no positive GNAS. But based on the size of the cyst that it was growing and on the findings that we saw with Cellvizio, we actually sent the patient to surgery. And she did have a mixed type of IPMN with branch and main duct, and she had intermediate grade dysplasia. So it really changed in the sense if we sent her to surgery sooner, especially since she was a young female. And even the surveillance interval that she had, we kind of base where the patient will, if we suspect IPMN, whether they have, based on the size, whether they go in a year or 2 years. Her CTs or imaging studies were sporadic based on, that it was a pseudocyst. So she could have developed, especially since she had intermediate grade dysplasia, she could have developed a cancer already. And so really in this young female, it was the right thing to do to send her to surgery based on what we found.